Hi, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you in the Dolph Simons Family Studio here in Kansas City, Kansas, and we are delighted to be back with you this wonderful, almost spring morning. And Hawkeye, we know the coronavirus is still out there.
Yes.
We got a pretty cool program today. We're going to update the vaccine rollout with KDHE Secretary Lee Norman. Lee, thanks for coming back. Always a pleasure to have you, sir. And Dr. Kevin Ault, an OBGYN and member of the CDC Advisory Committee on Immunization Practices. We're going to talk about the J&J vaccine. We're going to talk about COVID. We're going to talk about vaccination in general. We're going to talk about life. So it's going to be a great program. But first, Hawkeye.
Yeah, we need these vaccines to get in many arms.
We do.
To help continue to prevent the spread of
darn right. Call to arms. How are we doing this morning?
And we're doing pretty good on that front as far as active infections. Only 15 active infections with 4 in the ICU and only 1 on the ventilator.
I like it, down from 16 to 15.
Yeah,
that is awesome.
34 in that recovery phase too. So hopefully, they'll be able to get discharged and go home.
Yeah.
Hayes is still doing pretty well. 13 total patients, 6 in that active infection and 7 in that recovery mode as well. So. I think we're happy right now with what we're seeing as far as spread and hospitalizations go.
This is a big moment in time as these things come out here, and we would often jump to reporter questions, but I want to bring Dr. Norman and Dr. Ault in because I think questions are going to be revolving around the vaccine. So, Lee, how are things going from your standpoint? How's Kansas doing? How are we doing with vaccination? What do you think is going to happen with J&J?
Well, first off, good morning, everybody. Good to be here again. Thank you. Throughout the state, we're doing quite well, actually. The numbers yesterday reported for 3 days were 639 new cases. And remember, we were in the 1,000 or 2,000 cases a day. So to be down to a couple hundred cases a day is pretty dramatic. Only 8 deaths. And again, every death is a huge loss, of course. But to have only 8 by comparison in a 3-day period is the lowest we've seen for many months. Hospitalizations, as Dr. Hawkinson pointed out, are way down. I'll be on again today with a meeting with the hospital leaders, and I'm sure that I'm going to hear from a bunch of very happy campers, not only having beds available and not filled by COVID patients, but also having staff back. The vaccine rollout continues to be solid. We had that 1 week where there wasn't anything shipped to us, essentially because of the bad weather and the planes weren't flying and whatnot. But last week was catch-up week, this week more so. We have, remember back in the day, a few weeks or a couple of months ago, we'll say, we had 45,000 doses a week, and now we're at more like 145,000 doses a week. We still have a little bit of a data glitch in terms of reporting the percentage administered, but we're between 70 and 80%. Even with that data glitch. So I think that vaccine is getting into arms and inventory is overall low. We consider inventory, i.e. sitting in freezers and on shelves, to not be where the vaccine is doing any good. But I'll tell you, every one of our counties and our vaccinating sites, we have over 1,000 vaccinating sites now. We don't have a shortage of vaccinating individuals. So I think we're good. J&J, the Johnson & Johnson product. And first off, Dr. Kevin Ault, thank you for all the work you've been doing. We've been so dependent on the work and the thoughtful analytic work you guys have done, and it's absolutely greatly appreciated. And I have great comfort knowing you're there because I know you. The J&J, we're going to get 23,400 doses this week. We're handling it as the third. The third weapon in the arsenal against the COVID virus. I mean, there's differences. I'm sure that Kevin will speak to some of those. But we have a lot of confidence in that vaccine, and we're pushing it right out this week, and it'll be administered. And I'll leave the detailed discussion of that to Dr. Ault, but we're really excited to have one more. We will have a gap now. They're not as a high production vaccine as the other ones, so there'll be a gap. I don't think we'll expect our next shipment of Johnson & Johnson until March 23rd. One thing that I think is disturbing is that this last weekend we had 8 positive B117 UK variant strains identified in Sedgwick County. It was all in one family.
Wow.
And it was big wow. Multi-generational family with 8 positive cases. And I'm sure that's just the tip of an iceberg for that region and really probably for the state. Those were all identified at our state lab. We're starting to do, and I've talked with a great deal of enthusiasm, as you know, about wastewater testing for the virus. We're also doing wastewater testing for the whole genome sequencing. So we'll get even more information coming in from a surveillance perspective. By the way, the case, we've now have had 10 cases identified of that particular variant. None of the other strains that we've talked about from the South Africa or the Brazil. Lastly, we continue to have immense, really, testing capabilities and capacity throughout the state. But curiously, the number of people getting tested per capita is dropping off. And I think one of the things that we have to do collectively as public health and medical communities is to continue to push for testing, because that's still a fundamental public health intervention where we early identify cases, and you don't have to be symptomatic or even exposed to anybody to be tested. It's still a critical piece. So if you out there think about being tested and it's readily available to you, do so, because that'll help us to further put a net over this thing, because I'm afraid that we could be lulled into complacency and end up allowing this to plateau off when we can continue to drive the numbers down. We do not want it to plateau off, so that'll be really important. So that's what I have for you today, Dr. Stites and team.
Well, thank you, Dr. Orman, and thank you for your service and your friendship, of course, over many years. Kevin Ault. All right, man, talk to us about the process, what you think of J&J. I think you can offer opinion now. You've taken your vote, if I remember correctly, so you can talk a little bit more. So talk to us a little bit about what you think's going on with this, and how did you think the proceedings were?
Well, if you want to talk about the process, so the Food and Drug Administration, the FDA, gave their emergency use authorization at the end of last week. That was in the news quite a bit. And then we met on Sunday and Monday to talk, mostly on Sunday, to talk about the Johnson & Johnson vaccine that you alluded to. So we were, we voted in favor, would be the short version. The Advisory Committee on Immunization Practices, the group that I'm a member of, makes the clinical recommendations after the EUA from the Food and Drug Administration. We voted in favor. We had a presentation from the company. The clinical trials for the three vaccines are different enough. There's a little bit of apples and oranges comparison, but they had an international 44,000 person placebo blinded controlled study similar to the other vaccines. The biggest difference is that this is a single dose vaccine, not a 2-dose vaccine like the previously EUA approved vaccines. And there are about 4 million doses available. I think Dr. Norman talked about that a little bit. The efficacy was measured a little differently. The big news, I think, is that this vaccine prevents the severe disease. They had a little more definition in the previous trials of what made a severe disease, and I actually took some notes. So 85% effective against severe COVID globally, and then 72% effective against moderate to severe. Part of that depends on where you cut it off. If you cut it off a month after you've been vaccinated, it looks a lot better than if you cut it off 2 weeks after you've received that single dose of vaccine. One of the sites for this particular vaccine was in South Africa, and they did have modest protection and protection against severe cases due to that particular variant. So I think the news was good overall. And then we talked about variants and vaccine safety more on the Monday meeting after we had voted on Sunday. And so the new director of the CDC signed off on our recommendations Sunday night. I think I saw on Twitter, either late Sunday night or early Monday morning. So yes, so those first 4 million doses of this vaccine should be shipped out. I guess another very practical consideration I should mention is that this is a vector vaccine that has handling characteristics similar to a lot of other vaccines we use routinely in medicine, so it doesn't require quite a stringent cold storage recommendation. So I think, when the vaccine supply eases up towards the end of this month and in April, this might be the vaccine that people would get in the doctor's office or at their local pharmacy.
So, Kevin, if you were offered Moderna, Pfizer, and J&J, and you got to pick from one, here's the hard question, would you pick one over the other?
Yeah, we usually don't make preferential recommendations at the ACIP. We usually recommend to give something. Really, the best vaccine is the vaccine you can get in your arm. Dr. Pan, wrote a editorial for the Washington Post on Sunday and said, vaccines aren't the key to get us out of this pandemic. Vaccinations are the key. And Dr. Norman said that too in a different way when he was speaking. We got to get the vaccines out into people's arms. So I don't think I would have any preference. The best vaccine is the one that you can get to.
When I looked at the data, I was like, I'd be comfortable getting any one of the three of these vaccines, honestly. And the one has this, one has that. But the data, to me, while differing in studies, is a lot more similar than it is different. Yeah. If I just had one dose of Pfizer or one dose of Moderna and got to wait 4 weeks, which is, clearly how long it's going to take to begin to be really, really effective, then I don't know that the numbers are really much different. 68 to 72% effective for a single dose of Moderna and Pfizer is probably right in the ballpark, I would think. What thoughts about that?
No, I definitely think it is. And most of those differences are due to study design between the different trials. So, no, I think the best vaccine for you is the vaccine that you can get, is short. We're still going to be, in a shortage situation for the next 4 to 8 weeks. So.
And then we're going to have so much vaccine we know what to do with. Well, we're going to have more questions for you both. Let's first turn to see if there are reporter questions. And I got some other questions for you. All right. Any reporter questions out there today?
Hi, it's Carolina.
Taylor, Channel 41. Oh, sorry, go ahead.
Carolina from Channel 5. I just wanted to see if you guys can explain simply, maybe for folks, some folks still seem to have hesitancy or view Johnson & Johnson as kind of a third place vaccine. So maybe what confidence can you instill? Maybe can you run us through the data a little bit more? I mean, I know you're saying the best vaccine is the one you can get, but some people are still kind of looking down on it.
Dr. Alt, I think that part of that may come from the idea that Pfizer and Moderna landed around 94% effectiveness. In fairness, after 2 doses and after 6 weeks, or 2 weeks after your second dose, and 5 weeks, I guess, with Pfizer. J&J landed in that 68 to 72% effectiveness, but really after only 1 dose. I kind of hinted at this earlier. When you go look at some of the things I'm reading about Pfizer and Moderna after 1 dose, it's somewhere between 60 and 80% effective. Okay, well, that's hauntingly similar to J&J. And I know that J&J is now talking about a 2-dose regimen that they're going to study. It feels like these are all the same thing. And that really each of these is a really good vaccination. And I think the thing in the Johnson & Johnson data where they said, look, we didn't have any in their data, as I recall it, no deaths and no hospitalizations once you had the J&J vaccine. That is a remarkable statement. It's hard to think of that as an inferior product. Thoughts about all my little diatribe there?
There were 5 deaths in the placebo group and none in the vaccinated group, and so against severe disease, which was not measured quite as nuanced in the previous trials, it looks really good. And so and a lot of our vaccines for respiratory pathogens are that way. Pertussis in children protects against children getting very ill. Influenza vaccine in children prevents against children dying of influenza. So it really read very similar to vaccines that we have data that goes back decades. So I don't think it's a third place vaccine. I think we should all be very happy that we're going to have a good supply of vaccine as we go into the spring, because we have 3 vaccines under EUA right now.
And do you think there's any chance we'll go to a single shot of Moderna or Pfizer? I'm going to go back to Lee Norman with that as well.
Oh, and that's a hard question I was going to put to him. But I can talk about that a little bit. So on Monday, we hashed out that data. So, and as you said, there are some data that 1 dose is modestly pretty good protection for the first 2, the Pfizer and Moderna vaccines. But some of the problems are that with that is that, there's not a ton of data, and we're under an emergency use authorization, the biggest emergency use authorization by orders of magnitude that the FDA has ever given in the 15 years that that's been an option. So there's not really precedent for changing horses in the middle of the stream, so I think there was a little anxiety about making a recommendation to change right now, especially knowing that there's going to be a lot more vaccine available. So, but that's something, one of the things about, being on the ACIP and reading about COVID is a lot of the stuff you read or think about, 1 week is going to change with more data within a few weeks. So we're certainly open to talk about that again. I'm sure we will talk about it again. But right now, I just don't think we're quite there to recommend single doses of those first 2 vaccines.
Lee Norman, thoughts about, first of all, do you think J&J is just as good a vaccine as Pfizer and Moderna? And then also about the single-dose regimen.
Yes, I do think it's as good. And our guidance certainly is get it. And we recognize that vaccines are voluntary. These vaccines are voluntary, and people can defer or opt out if they choose to. If they want to take a whack at getting it later, getting one of the Pfizer's and Moderna later, even though Johnson & Johnson, I think that would be a very ill-advised strategy. I think a vaccine today is better than one at some undetermined time in the future, because we're still seeing a fair number of cases and even some deaths, as I mentioned at the top of this show. So I'd recommend getting it now. As Dr. Ault points out, we've had terrific success with all the vaccines, with these vaccines to date, and we'll get more and more information as time goes on. We don't know if there'll be a booster dose of the J&J that will be recommended as time goes on, but I'd recommend sooner rather than later. I consider that first dose to be all critical. We just don't see serious illnesses even in people that have had the first of the 2 doses. So yeah, really optimistic about it. We're treating it just as a normal vaccine, and the 3 are co-equals, really.
Hawk, what do you think?
I think that's good. My father's already received his because he's a teacher in Illinois, and he's in education. My mother hasn't. If she gets a chance to get any of those vaccines, I think she should go and get any of those vaccines that are available. The other thing to state, and Dr. Ault can help with this, is we actually have good data about South African variant and the Johnson & Johnson. I'm not aware that we have specific data for that. The trial did assess that, and over 95% of the people who were vaccinated in the South African arm of this did have that South African variant. And it did show excellent protection for critical disease and death, and those are the important things.
Dr. Ault, thoughts about that? Because I know that Pfizer and Moderna have hinted that they think they're still going to have it, but I believe J&J was the first one that said, yes, it works.
Well, some of that was happenstance because they did have clinical sites in South Africa right when that variant was taking off. So, but yes, a similar story. There was a modest decrease. I wrote down 52% in moderate disease, but if you start looking at longer time away from the dose of vaccination or more severe outcomes, there was still protection. So the news was good. And we actually talked about variants quite a bit on the Monday meeting, and overall, the news is good. There's a fair amount of in vivo data about the UK variant that makes it look like we're going to continue to have neutralization of that virus in vitro and hopefully in vivo, because that one was mentioned, it's come to the United States already. So, and good news about the South African variant as well from the Johnson & Johnson trial.
And I would also like to say, we have some real world data now from Pfizer in Israel, and we have some of the data from the Johnson & Johnson showing that actually decreases asymptomatic disease in people, so people who get the disease and have no symptoms. You would hope then, if you could extrapolate that set of data, that would overall cause a reduction in transmission overall reduction and spread of the virus. And so that is the way to get back to normalcy, stop the transmission and spread of the virus as soon as possible. And we know everybody wants to get back to doing normal things, going out, being with friends, going to the K, going to Arrowhead. And so the more people that can get vaccinated quickly when it's available to them, go get that vaccine. Hopefully we can overall continue to decrease the spread of the disease.
Let's see if there's other reporter questions.
Hi, guys. Taylor, Channel 41. Good morning.
Hey, Taylor.
So I have two questions. One is about the warnings we're hearing now in J&J from different Catholic dioceses around the country. I know we've talked about this. I know Dr. Hawkinson, we've talked about this with you with previous vaccines a good bit too. But with this particular, there's new warnings to Catholics not to choose J&J with Pfizer versus Moderna. I was going to ask if you guys could comment on that. And my second question was, I feel like I haven't used the words contact tracing in a while, and it seems like that is not gone away necessarily, but it just doesn't seem to be as front of mind. I'm curious about what the vaccines being out there now, albeit at a small percentage of being out there, has done to contact tracing. If you could do kind of update us on the situation right now on what exposure means when it comes to contact tracing and how the vaccines factor into that.
All right. Well, let's just hit that contact tracing one. I'll go right to Lee Norman with that because you're totally immersed in that all the time still. So what do you think about Taylor's question about that?
Yeah, that's we have a lot less pressure on our case investigators and contact tracers. We have even peeled some of them off to do other duties because of the fact that the numbers have come down. I hope not to have to flex up because we brought aboard dozens of additional case investigators and contact tracers during this. We have supported the counties. A lot of times the counties, 100 and plus county local health departments have been swamped. And so that's why we built up that capacity at the state. But really, it's going on unabated. So we're doing the same approach as we have all along. So no change, just less of a demand because we're not as overrun as we used to be, even as recently as a couple months ago.
All right. So what do you think, Huck, about this question about what's in the J&J vaccine and Catholics shouldn't get it?
Yeah, I'm not aware of that. I know that certainly it came up with the original Pfizer vaccine. We know that initially in the early parts of developing these vaccines, they have used cells that continue to grow. They're from aborted fetuses. But the Vatican has come out about this. The U.S. Conference of Catholic Bishops has come out about this. I saw Archbishop Naumann last night, and he plays a prominent role in the USCCB. And they came out with a statement saying, you need to get your vaccine. It's not mandatory, obviously. It's not forced on anybody, but you can get your vaccine, and getting your vaccine in no way contributes to that act that was done 40 years ago, 50 years ago to obtain those cells that are used in the early parts of development of the vaccine. So unless there's a new issue out coming specifically with Johnson & Johnson, which I wouldn't understand why there would be, because it's really a lot of the same process from the Pfizer and Moderna vaccines. Again, it's early on in the process, and the official statements from the Vatican and the U.S. Conference of Catholic Bishops is that you are not contributing to that act. You can still get the vaccine. It's not morally wrong to go ahead and get that vaccine. So unless there's other new statements by other specific dioceses or parishes, I'm not aware of those, but certainly happy to look at those.
Kevin, anything you have? I don't know. Did that come up to the advisory committee at all?
It did not come up to the advisory committee. Sometimes it comes up in public comments, but I don't think it did that time. So no, I had not heard this. As Dr. Hawkinson pointed out, these cell lines date back to the 1960s and, continue to be used for the measles, mumps, and rubella vaccine and have been for decades. So it's not a new issue, but the Vatican, as mentioned, has talked about it already.
Okay. All right, Taylor, sounds like we'll be doing a little more homework around that question. We'll be back with you about it, too. Okay. Any other reporter questions? All right. Let's turn to our public questions then. Let's see what we got. I bet there are a few.
One or two.
Okay.
We've got one that sounds like it's just right for Dr. Norman, and a lot of people have been asking, will having this third vaccine help us get through the different phases in Kansas faster?
Oh, I'm ready to talk to Norman about phase questions.
Yeah.
Yay! All right, here we go,
Phasers
buddy.
set on stealth.
Load it up.
The answer is yes. Really, it's a numbers game. The more vaccine we get in, whether it's any one of the three, will help us to move through that. You know, we're finding ourselves with some counties that are moving through phase 2, which is the phase we're in now, faster than others. So we are kind of redistributing as week by week goes on to those counties that are, for whatever reason, are lagging a little bit. And because we want to kind of load level across the state, not have counties that go into phase 3 or beyond while other ones are still in phase 2. Why? Because if you leave people behind in phase 2, those are the highest risk individuals. So we want to make sure that we load level and do the best we can. That kind of fine tuning, by the way, operationally speaking, is a little bit difficult. And quite honestly, it's a little bit unpopular. Some counties have said, wait a minute, we're getting at the end of phase 2, want to move into phase 3, and we're being penalized. And the answer is, no, not being penalized, but we're in this together as a state, and we want to move through the phases because they're high risk people. We don't want to leave them behind. So we are redistributing sometimes 20 or 30 counties at a time for a particular week, for example. So we're going to continue to do that. That's a policy that we think makes sense for the greater good of all Kansas.
And so, Dr. Norman, do you see a time when Kansas will open up to just any phases? Do you think that as we get more vaccine, we're talking about maybe getting 200 to 300 million more doses between now and June 1st, and really between probably April and June 1st. If that happens, do you see where we're just going to say, okay, we're just going to open it up?
Yeah, I think that could happen, Steve, because, you know, you think about it, we're going to get about 2/3 of the way through phase 3, have our older people, and particularly those with moderate or severe medical conditions. Once they get vaccinated, the rest of the populations going forward are more homogeneous than the ones we've wrestled with up to this point. Of course, the unknown, and this is a good Kevin All question, is about children, because we have, I think, 500 or 600,000 young people in the state that don't qualify for a vaccine now. So you can kind of, if we have 3 million people in the state of Kansas, you can take those out of the mix. I'm hoping, you know, by late spring, we can pretty much go through the phases with all the over 16 or over 18-year-olds and have a relatively, maybe amazing summer. I would like us to have a period of time that we have good luck and good results converging to have a really great summer.
Yeah, let's go Royals at the K. So one thing, Dr. Norman, do you see a time, right now it's going to the counties, do you see, and a little bit to pharmacies, do you see a time when, you know, I'm very biased and this is a personal question, obviously self-interested, sorry about that, that's my editorial comment. Do you see a time when health systems and hospitals will be getting vaccine directly, or will it always come from the county health departments?
No, matter of fact, it's already not only coming from county health departments. The feds are pushing directly to pharmacies. Of the 1,400 vaccinating sites which are registered, most, of course, don't have any vaccine yet because we don't have enough vaccine to do that. But 640 of those 1,400 are pharmacies. So, and a lot of those are small or non-chain pharmacies, i.e. locally owned and operated pharmacies. And yes, absolutely, doctors' offices. You know, who's the best person to vaccinate and convey that message that vaccination is safe and important, but a doctor. And that's been proven. That's not just my opinion.
Absolutely true. Absolutely true. One of the places I think the J&J vaccine is going to have a really big spot, because it's so much easier to handle than Moderna and Pfizer, is moving to physician offices. Thoughts about that?
We already have talked about that. Matter of fact, if we had a continuous flow of vaccine right now from Johnson & Johnson, we would be doing that right now. As again, with this small amount, 23,400 doses coming in this first allocation, and then nothing until the 23rd, J&J isn't going to have a huge impact on the state, except it will for those 23,400 that will then be fully immunized. Yeah. So, and doctors' offices would be ideal. As Kevin mentioned, the storage is much easier. It's got a longer shelf life. It's less finicky to handle. It'd be ideal for doctors' offices, and we definitely will do that. We have a lot of doctors' offices. We're working with the professional organizations, the Kansas Medical Society, the the Kansas Academy of Family Physicians, Pediatrics, et cetera, and we want to get it in their hands as soon as possible.
Well, and I think hospitals are uniquely positioned as well to give it. And one of the other thoughts is when you have patients who are leaving the hospital, going to nursing homes, is J&J the perfect vaccine to give them? It's one shot and they're gone. You don't have to worry about follow-up. And I know there's just a lot of ways, and I sit back and look at it. I think J&J is a big hit, and I think it's going to be really successful. And I think we got to get over this idea that's inferior, because to me, there are so many good uses for the J&J vaccine. Dr. Ault, thoughts about that? Did the CDC Advisory Committee think about what's the best usage of the different vaccines?
There were quite a few opinions. We didn't make any recommendations, but I think several people, both within the group and in the bigger audience and public comments, said what you just said. You can definitely see some areas where a single dose vaccine is really going to shine, especially with those handling characteristics. So yes, I mean, we didn't make a preference for any version of the vaccine, but lots of people expressed the thoughts that you just expressed.
All right. What's different about the J&J vaccine? Is it any different from Pfizer and Moderna, and how it works in the body?
Great question. Let's turn to Dr. Ault and then to Doc Hawk about that. How is it different inside the body?
So the first two vaccines, the Pfizer and Moderna vaccines, were based on messenger RNA. So when they get into the host, they make the spike protein that you saw in the opening sequence for this conference. And so the host recommends it, and the protein provokes an immune response. For this new vaccine, there's a vector, an adenovirus, that's a human adenovirus in this case, that has been modified so it doesn't replicate, so it doesn't reproduce in the human body. And the genes for the spike protein are within the adenovirus vector. And so it's quite a bit different delivery system. However, that backbone, that adenovirus vector, has been used extensively as vaccine candidates for Ebola and HIV. And so there's a lot of, again, similar to the other vaccines, there's a lot of, there's a decade or two of pre-work that went into this before, we got to this point. So they're different, but the news is good that, there's a fair amount of background with both platforms.
Yeah. I mean, the payload and the main thing that we're looking at is you both have the end product of the spike that you are presenting and creating and mounting an immune response to. So the adenovirus vectors, like Dr. Ault said, have been used in other vaccine candidates. It's important to note the DNA goes into the nucleus from that adenovirus vector, but it does not incorporate into your cells. It doesn't get into your genome or your DNA. It basically just snips out that little piece that encodes the spike protein, and then you start to make spike protein from that DNA that has gotten into the nucleus. So it is very safe, and those are the main differences, really.
Okay, so I don't want to confuse the audience any further, but Novavax is still out there, and preliminary data look pretty good. Mm-hmm. So, Dr. Ault, where do you think Novavax, will it come to the CDC Advisory Committee? What's the timeline for that? What do you think is going to happen?
Usually it's the FDA that hears about the timeline. We usually react to the FDA. And so, you could probably find that information on the Novavax website or the FDA website. Novavax is a little different than the two other vaccines we talked about, and maybe a little bit more traditional. I guess it's actually the spike protein. It's a protein-based vaccine. And we have some other vaccines that are somewhat similar to that, the human papillomavirus vaccine, the hepatitis B vaccine. So it's, it's a protein and you inject it. And if I remember correctly, the phase 3 trials are 2 doses, but I would have to check on that. So, and the preliminary data for that looks good. So yeah, I don't want to speculate, but I'm hopeful that we'll have an EUA for that at some time in the future.
Yeah, I think that it is 2 doses. So Lee Norman, my question to you is, once you have Pfizer, Moderna, J&J, and Novavax, will you still have a job and have anything to do?
Yes, I hope not. This has been more of everything than I wanted. But yes, I wear 2 hats. I'm the secretary of KDHE, which also includes that multi-billion-dollar program called Medicaid, the environment, so clean air, clean water, and oh, by the way, public health. So I'd be happy to have a little bit less of a job. I did want to make one serious point, though, and that is, one of the things we've been seeing with the vaccine uptake is that some people have been concerned about the mRNA because it's something kind of new and different, and have been deferring, waiting to see. So I think that Johnson & Johnson, per Dr. Hawkinson's point and Dr. All's point, is a different enough and very familiar, time-honored approach to making a vaccine. I think for those people that have been hesitant, rightly or wrongly, about the mRNA technology, maybe this will meet their needs psychologically to provide them the comfort that they need to go ahead and get vaccinated.
Yeah, I think that was a great point.
Okay, so the thing I've been dying to ask Lee Norman is whether it's still Christmas in his condominium, because there's something like cardinal behind you, it looks red and green. And what are you doing there? Do you know that was like 3 months ago?
I'm reaching the point where I might just leave it up for next year.
Well, I don't see a tree, but I thought, does he really still have Christmas decorations up? I'm going to have to call attention
with
to
the
that.
vaccines, it's Christmas all year long.
That's it. Every day is a new day, Lee Norman.
Well, I've been busy, Steve. I mean, this is my 59 weeks we've been in incident command for this thing. This is my fourth day of working from home, and then you go and then embarrass me for having my Christmas decorations up. Shut up.
We have a long history of embarrassing each other, so it just fits the pattern.
All right. A lot of people asking, what side effects are there from the J&J vaccine, and how do they compare to the Pfizer and Moderna vaccines?
Yeah, great question. Dr. Alt, what I was reading, maybe a few less side effects, partly because there's only one dose.
Yes. So if you look at we talked about this on Monday, if you look at the RNA vaccines I just mentioned, it's the second dose tends to have fever and muscle aches and those type of things with it. And a majority of people had those reactions to the second dose of the RNA vaccines. The new vaccine, the J&J vaccine, has side effects that are similar to other vaccines that you get intramuscularly. You get a sore arm and that type of thing, but it appears to be a little bit less reactogenic. But you should still, expect a sore arm just like you have from your flu shot if you get one of these vaccines.
And Hawk, when we look at our patients, in the injections we've given with Moderna and Pfizer, no real serious complications.
No, we've given, 30,000 now?
I think 30,000, yeah.
That includes first doses and second doses, and really nothing significant. But we know that those systemic symptoms, like just feeling bad or the fevers, those are pretty prominent in the studies, but also in our real world and anecdotal and talking to our friends that have gotten it. But I think overall, those types of things are definitely less with the Johnson & Johnson vaccine. So.
Yeah, I know I got it from the second dose. I got the high fever and had a day of feeling pretty crummy. You know what? Bring it on. I do it again. There is a little bit of a feeling of confidence. Not false confidence. Still wear your mask and follow the rules of infection control. Don't dare violate them. But you do have a little bit more confidence. There is a little sense of relief, I think, after you've been vaccinated. Because you feel like, okay, I may get it, but I'm not going to die. I'm going to be okay. And there's a certain amount of peace that comes with that.
Yeah.
And I science, right? Faith, hope, and science. It does tend to work, that science thing.
So we've heard about how this works with the Pfizer and the Moderna, but do we know if the J&J vaccine will help keep us from transmitting the virus to others?
Great question. I think there's actually some preliminary data around that, Dr. Alt.
I wrote that down. Now I'm looking for it. But yes, the number I was remembering was 75% protection against asymptomatic infection. So yes. And there's hints of data. I think Dr. Hawkinson actually said this earlier from Israel about the other vaccines. So we're starting to see some data that you do prevent asymptomatic infection and spread from these vaccines.
And that's a big deal because that Israel data was helpful for thinking about that.
Yeah, I think it's huge data that we can use to extrapolate, again, because we know that up to 40% of people with COVID-19 can be asymptomatic. And that's the danger, and that's how this disease spreads. We know that for the original SARS, you weren't really you weren't really infectious to other people until about 5 to 7 days after your symptoms started. if you have 40% of people who are asymptomatic but also can transmit that disease 1 to 2 days or maybe even more before any symptoms, if we have real data now showing that there is a significant reduction in asymptomatic disease, you would hope that, again, by extrapolation, you can then protect against further transmission of the virus. So I think it's all, positive.
Some of our viewers have read that Johnson County will soon start receiving only the Pfizer vaccine from the state, and the last second-dose Moderna clinic scheduled for this Friday is it. So what happens to those who still need their second dose of Moderna?
All right, Lee Norman, help us dispel this terrible rumor.
Right.
It's a terrible rumor that must be dispelled.
That's why we brought it up.
All right, well done. Okay, keep going.
To put a little finer point on it, we are obliged to give everybody their second dose of whatever they got the first time. And we will move mountains, of course, to make that happen.
All right. What about mixing Johnson & Johnson or Pfizer or Moderna? They know that the first two, they say it's not recommended. What about throwing the third one into the mix? Can that be done?
Who wants this question, people? Okay, okay.
We did talk about it at ACIP. Again, in the absence of data, it's hard to make recommendations about that. And usually that's true when any vaccine is approved. That data about mixing and matching usually comes later, along with simultaneous administration. So I think the only situation where you would get the Johnson & Johnson vaccine after you had gotten one of the other two vaccines, if you were one of the unfortunate 1 in 200,000 people that had a severe allergic reaction, because it's unlikely to be a reaction to the second vaccine. And so that might be the very unique circumstance where you would mix and match. And Dr. Hawkinson kind of just said this, the allergic reactions have panned out to be the 1 in several 100,000 doses. That's why we've not seen any in 30,000 doses at KU.
Yeah, I think it's a great question. Right now, the guidance is you can switch or mix in exceptional circumstances. Right now, I don't think that really any vaccination sites around the nation do have those exceptional circumstances because, just as Dr. Norman said, when you get your first vaccine, most of the time you are going to be scheduled for your second vaccine, or you're at least going to put in a pool to be scheduled for that same vaccine. You really shouldn't mix and match other than what Dr. Alt talked about unless you had a severe reaction to that first dose of Moderna Pfizer. Because after you get Johnson & Johnson, you're not going to be mixing and matching because it's only a one-dose thing. Now, as we move forward and we do expect boosters or, pivots on that vaccine based on variants, there may be some mixing at that point. But right now we aren't there. We just have to kind of wait to see what happens. And we know that those studies are going on for mixing, particularly with the AstraZeneca and the Pfizer vaccines.
All right. Dr. Norman, final thoughts. I know you're going to have to drop off here in just a second.
Yeah, I had one more thing I wanted to talk about, and that is, again, about optimism and resiliency. We've given between 600 and 700,000 doses of the first two vaccines in the state of Kansas. In a couple of weeks, we will have received 1 million doses into the state of Kansas. And we follow the adverse, the vaccine reporting system to, if there's anything that's cropping up that is an adverse event following a vaccine, and we're just not seeing it. So in keeping with what Dr. Ald and the rest of you have said about the safety profile of this, it's just remarkable. And again, we're talking real numbers now. We've given between 600 and 700,000 doses already, and really haven't seen anything crop up. So very safe vaccine. Keep getting them and be optimistic. Get out in the sunshine.
Yeah, so true. Yeah. Dr. Ald, final thoughts.
Well, you usually ask me about pregnancy, and so there was some safety data on the Monday meeting about the first two vaccines and pregnancy, and similar to what Dr. Norman just said, we haven't seen any increased pregnancy complications as far as stillbirth and miscarriage and that type of thing. There are 1,800 people they're following in the VSafe app, the one that if you sign up for the vaccine, you can sign up for on your phone, and everybody should do that if they are getting vaccinated soon. There are 30,000 people that got vaccinated in another one of the safety systems. I don't want to look at my notes, but there's a ton of pregnancy data that's going to be coming out, and the first pass of it on Monday looked very good. And so I thought that was reassuring, because we put a lot of our healthcare workers in a spot, where they were getting vaccinated back in December and January when we didn't have a lot of data. And so people can rest easy that it's what we expected.
And any comments you want to have about pediatric immunization and getting it to children sometime?
Yes, we should have some of our colleagues from Children's on, because they're doing those trials. We talked about that at the end of January, and again, the pediatricians might be able to explain this more. And Dr. Norman kind of alluded to this. We're going to go backwards, starting at age 17, to 12 to 17-year-olds, and I think that is fully enrolled for several of the vaccines, then keep going backwards and down in age. And, there's a very precise way to do that. And people are volunteering their children to be in those clinical trials. I think Children's Mercy Hospital is a little bit overwhelmed with volunteers, which is a good problem to have. So, yeah, we're going to go backwards, like we usually do for these vaccines, and have data very quickly, hopefully.
Thank you both for joining today. So appreciate that you were here. Hawkeye, final thoughts from your standpoint?
Yeah, I think there's a lot of reasons to be optimistic now, moving forward, getting into a spring and summer where we can enjoy some things again, not like last spring and summer. But just as Secretary Norman said, it'll probably still be several weeks, 4 to 6, 8 weeks, before we can really get that supply of vaccine and get those into arms. So until that time, please continue to be vigilant. Let's continue to see all of those cases drop, all of those hospitalizations continue to decrease, and of course the deaths to decrease. We got a little bit more time, but all of the data right now from all of the vaccines that are available, and even from the vaccines that are hoping to be available soon, look to be really good and one step closer to normalcy. But we still got a little bit of time to continue to be vigilant.
Hey, tomorrow, this is a cool program. We're going to talk about COVID-19 and how it's impacting the need for liver transplant, your ability to get a transplant, what happens if you're transplanted and then you develop COVID-19. Dr. Ryan Taylor, who's a hepatologist and our medical director of liver transplant, and Dr. Tim Schmidt, who is our overall director of transplant here at the University of Kansas Health System. They're both going to be joining us and talking about this issue. I can see some lung transplant patients, and this is a pretty cool area, and I think it'll be an interesting discussion. If you know anybody that's been transplanted, has a loved one who's been transplanted, these guys are a great wealth of information, and I look forward to making sure we have a good conversation around how does COVID-19 and how does vaccination impact transplantation? A really big deal. A shout out to Dr. Kevin Ault and Dr. Lee Norman. Thank you guys so much for joining the program today. It is a delight to say the number 15. That feels so good. And there was a time when we thought 15, we were scared, but man, 15 feels so good. But don't you get cocky, because this little bugger is still out there. And if you're not careful, it'll come for you, because it wants to any minute now. So remember, and by the way, Andy Reid, I'm available. 60 years, low miles, a little bit of rust. I'm here in case Patrick has any problems. I'm right here for you. Just give me a call. I'm ready to go. But no, seriously, COVID is still out there. And remember that even if you haven't been vaccinated, and frankly, even if you have been vaccinated, you still need to follow the rules of infection control, because we keep each other safe, and that helps us all get back to normal. They're talking about 8,000 fans at the K, and maybe this fall, we can go full throttle as the Royals go back to the playoffs and the Chiefs get ready to climb the summit. We can be there, and for sporting, nothing like the Cauldron at full throttle.
That's right.
We can do that, but it takes all of us. And the way we can do that is if you follow the rules of infection control. Remember, still wear your mask. Don't go out if you're sick. Keep your distance. Cough into your elbow. Take care of your community. And remember, there's still no place like home. We'll see you tomorrow.